Hello, and welcome to our online interactive update for the C3 IFT transport protocols, teaching you how to use insulin and Levo. So today we're going to discuss IV insulin, its uses and its dosages, and how we can monitor an IV insulin drip. We're also going to discuss Levo and how to monitor a Levo drip. Unfortunately, monitoring a Levo drip is going to involve a little bit of med math, so get out your calculators. I know everybody loves med math, but we'll try and make it as easy as possible. The first drug we're going to talk about is insulin. Insulin is a hormone that is produced by the pancreas. Basically, it takes sugar that we ingest in our diet and converts it into usable things, like glycogen or into lipids. Insulin is great because it helps keep our sugar levels in balance. People with diabetes sometimes have a deficiency of insulin, so their sugar levels can go high or low depending on their diet and how their body works. It's also worth noting there are several kinds of different insulin. There's Humalog, Novolog, regular, long-lasting. For the purposes of IV infusions, we're going to be dealing with regular insulin. Insulin is produced naturally in the body, but if we're going to give it IV, we're going to give it for reduction of serum blood glucose levels, the treatment of DKA or HHNS, or hyperkalemia. So here we see the differences in DKA, diabetic ketoacidosis, and HHNS, hyperosmolar hyperglycemic non-ketonic syndrome. DKA, obviously the onset is much faster, and the blood sugar levels are typically lower, 300 or less. And then with HHNS, it's above 600. Also with DKA, you're going to have your pH is going to be lower, so you're going to be a little acidotic, as noted with the acidosis. The treatment for both is basically the same. You're going to do a 20 milliliter per kilogram bolus of normal saline and repeat as needed. Of course, 1,000 cc's of normal saline is only going to drop your blood sugar about 10 points. That's where the IV insulin comes in, the slow, controlled reduction of your serum blood sugar to get it down to a normal range to prevent organ damage and so on. You can see that IV insulin is noted on both treatment modalities for DKA and HHNS. And this is most commonly where we're going to see the IV insulin drips in the C3 transport setting. The side effects of insulin obviously are going to be hypoglycemia because it's reducing your blood sugar levels. If a patient is left on IV insulin too long, they can become hypoglycemic. So as we're going to see in the next slide, it is important to routinely check a blood sugar. Patients that are on IV insulin drips for extended periods of time can also become hypokalemic. Because of the way insulin works, it helps move potassium from outside the cell to back inside the cell, so serum potassium levels can drop. The onset of action is almost immediate when given IV, and when you're on a drip, the peak effects are going to be in 2 to 4 hours. So here we see the West Virginia CCT guidelines for administration of a insulin drip. I know these are CCT, but this is a good starting point for us to look at when we're going to be monitoring an insulin drip. So if available, make sure you consult the patient's record before leaving the hospital to check their glucose and their potassium levels on the lab report before you leave. This should be available to you in the packet of patient information. We want to make sure their potassium is at least in the normal range before giving an insulin drip. If their potassium is low, it could become lower by having an insulin drip. Also, we want to monitor our glucose every 30 minutes and make sure that we have some normal saline hanging along with the insulin drip. Insulin is most commonly mixed with 100 units of regular insulin in 100 milliliters of normal saline, so that makes it 1 unit per 1 ml. The most common dosaging is 0.5 to 1 units per kilogram per hour. Titration can be ordered by the physician, but most likely in the C3 transport realm, titration will be complete by the time you arrive at bedside, and they will have a stable reduction in blood glucose established. So in Module 2, we're going to start talking about Levo. So Levo, or norepinephrine, is a potent vasopressor. It's most commonly used for life-threatening hypotension. This has become extremely popular with sepsis protocols. when IV fluid has failed to maintain adequate perfusion. The drip is going to be given to maintain a predetermined blood pressure, but more accurately, we want to maintain a map of 60. That's our most accurate measurement of body perfusion. So what is the MAP, or the mean arterial pressure? Basically, the MAP is your systolic blood pressure plus 2 times your diastolic blood pressure divided by 3. Your target MAP is 60. Note that our LifePak 15s will automatically calculate a MAP for you if you're using the non-invasive blood pressure. Keep in mind that the non-invasive blood pressure is historically inaccurate. So here we have our drug card for Levophed or norepinephrine. Levophed is an alpha and beta adrenergic agonist. Basically, it's going to increase our inotropy and our chronotropy of our heart. It's used for inotropic support for blood pressures less than 70 with signs of decompensation. It's preferred in cases of sepsis with profound hypotension. You have your adult dose listed here, which is the same dose I gave you, and we don't want to exceed 30 mics. Worth noting here, the contraindications to Levophed infusion are hypotension associated with hypovolemia. So let's think about this. If we're going to increase our inotropy and our dermatropy, so we're going to squeeze down our vessels and cause some vasoconstriction, it wouldn't work very well if our vessels were empty. So Levophed should only be administered when hypotension persists despite volume replacement. You want to make sure adequate volume replacement has happened before they're giving Levophed. So for sepsis, that's usually 3 liters of normal saline prior to starting a pressor. It doesn't do any good to squeeze down the pipes if the pipes are empty. Levophed is most commonly mixed 8 milligrams in 500 milliliters of D5. It can be mixed differently, and it is almost never prepackaged as a drip. Fairmont Regional mixes it 8 milligrams in 500. It's also worth noting that this should never be mixed in normal saline. It has a very bad reaction. It should either be mixed in D5 or LR. Levophed is administered 0.5 to 1 micrograms per minute and then titrated in 0.5 microgram increments to a desired systolic blood pressure or a desired MAP. The maximum infusion is 30 micrograms per minute. It's going to be titrated to a physician's order. If you look in the ACLS protocols for return of spontaneous circulation, they have Levophed listed as a weight-based infusion. It's not given often that way, but it can be. Most often it is given as a non-weight-based infusion. So let's review some MedBath. When we're calculating a weight-based or a non-weight-based drip, here are our formulas. And keep in mind, because we're going to be running this on a pump, we're going to want our answer to come out in milliliters an hour. So that's 60 here, where we would normally be using this as a 60 drop set in the field. It remains as 60 because there's 60 minutes in an hour, and we want milliliters per hour for our pump. So your dose times 60 divided by your concentration for your non-weight based, or for your weight based infusion, you're going to have your weight in kilograms times your dose times 60 divided by your concentration. So we first need to establish our concentration of medication before we can move on with figuring out the rest of the problem. Our pharmacist has mixed 8 milligrams of Levophed in 500 milliliters of D5W. The only problem with that is our dose of Levophed is administered in micrograms, so we need to convert this to micrograms in 1 milliliter. To get 8 milligrams to micrograms, we simply multiply by 1,000. There are 1,000 micrograms in 1 milligram. So that gives us 8,000 milligrams in 500 milliliters of D5W. To figure out our concentration in 1 milliliter, we simply divide 8,000 divided by 500 equals 16 micrograms in 1 milliliter of D5W. We now have our concentration. Now we're going to plug in some more numbers. 0.5 micrograms per minute, that's our starting dose. And remember our 60 over here for our drip set over 16, that is our concentration. Your answer is 1.875 milliliters an hour. and you can set your pump to that infusion. So here we have a word problem. We're going to arrive at the bedside. The nurse states the patient is receiving 3 micrograms per minute of Levofed. The pump reads 11.3 milliliters an hour. The bag states there are 8 milligrams of Levofed mixed in 500 milliliters of D5. The patient has a blood pressure of 76/40, and the doctor would like you to titrate the medicine up. So the questions we need to answer for this: is the medication infusing at the rate the nurse stated? So are they getting the dose the nurse said? And now we want to titrate the medication up to 3.5 mics a minute. So for our first part of the problem, we want to plug in our 3, which is the dose they state is running, multiplied by 60, over our concentration, which we know is 16. And the right answer is yes, it is running at 11.3 milliliters an hour. Now we need to figure out what will 3.5 mics per minute of Levofed look like. So we take our 3.5, which is our dose, multiply it by 60, put that over top of our concentration, which is 16, and the math works out to 13.125 milliliters an hour. Thank you for watching today's presentation. If you have any questions, please shoot me an email. Otherwise, enjoy the rest of your day.